Welcome to the JACC Edge podcast. This is your host, Pratik Doshi. I currently serve as the editor for the JACC Edge monthly newsletter, where we do a deep dive on hot topics in cardiology with experts. Today, we're joined by Dr. Piccini, who is the director of cardiac electrophysiology at the Duke Heart Center and serves as the associate editor of JACC-EP. Dr. Piccini, it's so great to have you here with us. Do you mind giving our audiences a one-liner about yourself?
Yeah, no, Pratik, it's great to be here. So I know you're at, I'm a electrophysiologist at Duke and professor of medicine, and spend a lot of time engaged in research and taking care of patients with atrial fibrillation. And I went to the University of Notre Dame, so I'm a huge Notre Dame football fan. So I'm glad you're at USC, but we probably will have some contentious debate come the fall football season.
Oh, absolutely. You know, this is going to be our year. That's what we say every year, and you guys have beat us pretty consistently. But you know, I really feel like this is the year we're going to turn it around.
Yeah, certainly your team's shaping up, looking for a really good season this year.
It's going to be a great football season. But to kind of dive into our topic a little bit, flutter or fib? That seems to be always the question. Our hearts might not know the answer, but the risk of being unable to diagnose this has severe consequences for our patients. Through better data and research modalities being applied to AFib management, we hope that one day this common disease becomes easier to manage. And I hope that through our conversation and some of the work that you're doing, we're able to drive into that answer a little bit. So to start us off, can you help us settle the age-old debate, rate or rhythm control? What should we do?
No, I think it is an age-old debate. And I think what's really interesting for me, and I'm not a spring chicken anymore, I remember when I was a medical student, my fourth year, I was doing an electrophysiology rotation. And the AFib results had recently come out. And everyone was like, oh my gosh, can you believe it? There was no significant difference. And I remember when CHF came out, and everyone thought, well, for sure, now that we're looking at people with heart failure, for sure rhythm control is going to be better. And we've had this, long-standing debate, but I actually really do think we're starting to get some answers. And so, as someone who spends a lot of time taking care of patients with atrial fibrillation and seeing them referred for rhythm control, I really do believe that the evidence is beginning to show that there is long-term benefit to rhythm control. And it's probably not surprising that that's happening now as we know how to use antiarrhythmic drugs more effectively. We now have catheter ablation, which is a very safe and highly effective procedure. And we have a lot of clinical trial evidence to help guide us in whom should we apply those therapies. So I think for all of those reasons, I think rhythm control is really appearing to be the answer for many of our patients, maybe even most of them. Are there patients who have truly asymptomatic atrial fibrillation and rate control is an appropriate option? Absolutely. But I think we're in a much different place than we were even 5 years ago.
Wow. So it seems like there's been a lot of development in this field. Can you talk about some of the work you might be doing in AFib at the moment?
Yeah, so I think when it comes to rhythm control, I was very proud to be part of the Cabana trial, which, while the primary endpoint was neutral, certainly there was a reduction in death, cardiovascular hospitalization, in an intention to treat basis. We are now, under the leadership of Doug Packer, looking forward to designing a Cabana focused on heart failure patients, particularly patients with heart failure and preserved ejection fraction. And probably the thing I'm most excited about is we're doing a pragmatic randomized controlled trial embedded in the Get With the Guidelines program called Change AFib. And East showed that application of rhythm control within 1 year of diagnosis appears to reduce cardiovascular events at 5-year follow-up.
Wow.
So our question is we all see, and in fact, 1 in 5 patients who comes into a U.S. facility for acute care of atrial fibrillation has a new diagnosis of AFib. And we don't have any evidence for those patients. We know that they need stroke prevention therapy, and we know they can't be tachycardic, but Change AFib is going to try and answer the question, does initiation of a well-tolerated antiarrhythmic drug therapy at first diagnosis reduce cardiovascular events and improve outcomes down the road?
Wow, that's a really important question that I think, you being an internal medicine resident at the moment is something that we often deal with on a day-to-day basis. And for you as, being an electrophysiologist, it's just a question that I think every physician who works with this patient population has, and I think that's going to really elucidate some great answers for us and improve clinical care.
Yeah, I remember when I was a resident and I was admitting patients with heart failure, and I remember reading a study where they showed that patients who received guideline-directed medical therapy for heart failure at hospital discharge had improved outcomes down the road. And the hypothesis is that getting patients on the right foot very early was super helpful. And that's our hypothesis with Change AFib. If we can maintain sinus rhythm very early and keep folks in sinus rhythm, we think they're going to have improved outcomes.
Yeah, and we hope that study really helps us drive care forward in that way. So AFib is obviously a multifactorial process, and there's been a lot of recent discussions, and some of your work has been on neuromodulation therapy, things such as sympathetic denervation or vagal stimulation as a treatment for AFib. Can you talk to us a little bit more about what that exactly looks like?
Yeah, so we recently wrote a review, and we were very purposeful when we wrote the review that we used some terms that a lot of young physicians don't use very often, things like vagal AF or sympathetic AF. And so it's been really well known for a long, long time that autonomic influences, and more importantly, sympathovagal imbalance can trigger and lead to atrial fibrillation. And what's really exciting is that for many, many years, we didn't have a lot of therapies dedicated to those specific processes, and now we do. So tragus stimulation, where a stimulator is put on the ear, there have been some sham-controlled studies, including studies at the University of Oklahoma with Stavros Stavrakis and his group that show that can decrease AFib burden. There have been studies that centrally mediated neurologic interventions can decrease AFib burden. There's been some studies that suggest potentially that impairing the autonomic ganglia around the heart can reduce the incidence of postoperative atrial fibrillation. Most of these studies are either not conclusive or are small, but when you look at them in aggregate, it really does suggest a lot of hope for neuromodulation being a way we can reduce AFib, and I don't think that they'll ever be standalone therapies, but we're now beginning to enlarge our war chest, so we have even more tools to bring to the clinic to help patients.
That's awesome. You know, when as a resident, whenever you show up to a rapid or code for a patient who's in AFib with RVR, the joke is always hand them the syringe and have them blow into it, and never works. But it sounds like the idea here is that we're shifting from just medical drug-based management to really pathophysiologic-based control of AFib, and I think that's a really interesting direction that EP and electrophysiology, but also AFib management in general, is heading.
Yes, I think where our autonomic modulation therapies are going to go is that we'll have some acute therapies that we use to prevent postoperative atrial fibrillation, for example, things we'll do during ablation procedures to reduce the risk of recurrence. But then there's going to also be some things we do that are like exercise therapy for peripheral arterial disease. Maybe our patients with atrial fibrillation will have a prescribed tragus stimulation wear time each week. And so I think it's really exciting to think about the future and all the different things that we may be able to bring to our patients.
Yeah, and I think you bring up a really good point where non-pharmacologic management, such as weight loss and dealing with some of the preventive health things that we learn about, either as med students or as residents, actually has a direct impact on AFib burden. And I know there's been a lot of studies that have been looking at that. Could you comment about non-pharmacologic management and how we deal with patients on that front?
Yeah, it's super important. And I think this is work that, Dr. Prash Sanders and his team and others have really led the way, but we know it's critically important. And in some ways, it's not like any other part of cardiology, right? We have to maintain risk factors, but we know that persistent hypertension, very strong risk factor for recurrent atrial fibrillation. We know that elevation in body mass index, very potent trigger and driver of atrial fibrillation. And we know that managing these things is really important. There's also some important lifestyle things. So it turns out even modest doses of alcohol can have a really, significant impact on someone's burden of atrial fibrillation. And now we have randomized data that shows that if people, abstain from alcohol, they will have significantly fewer recurrences. Maybe that's not the most fun advice to give, but for people who are really struggling, with their burden of atrial fibrillation, those are the types of things that can be very helpful. And you're exactly right. Drug therapy is one thing, and it's one of many things we need to pay attention to.
Yeah, absolutely. I think there's a little bit of poetry in the idea that, while even though it's 2023 and we're innovating with gene therapy and all these other things, the basics always ring true. Make sure we counsel patients on alcohol cessation, smoking cessation, obesity, hypertension management. And I think it's kind of endearing to see that those things always hold true.
Yeah, no, the more things change, the more they stay the same.
Exactly.
Right?
It's like, when we're doing POCUS and ultrasound, the stethoscope still is going to be, I think, a mainstay of how we go about and assess patients.
Yeah, I think one of the things, if I reflect all the things that have changed about AFib is, there is such an explosion of knowledge with respect to atrial fibrillation. And in particularly, we're having a much better understanding of the relationship between glycemic control, diabetes, and AFib. We have a much better understanding of the relationship between obstructive, disordered breathing, atrial fibrillation, and maintenance of sinus rhythm. And those connections are so much more rich and well understood than they have been in the past. Granted, we have a lot of room to go, but it's a really exciting, path forward.
Yeah, and I think it's a really exciting time for all of us, seeing this field blossom in this way. I'm really excited to see where we head in the future. Well, Dr. Piccini, thank you so much for your time. Thank you for sharing your insight with us. For our listeners, if you're interested in learning more about AFib management as well as other hot topics in cardiology, please subscribe to the JACC Edge newsletter and catch us wherever you get your podcasts. And this is your host, Pratik Doshi. We hope to catch you next time on our podcast. Thank you so much. Thank you again.
Thank you, Pratik.